Welcome to the Moxie OT podcast, where we invite occupational therapy practitioners, consumers, and friends of OT to talk about evidence-based practice. Today we're discussing OT's role in the intensive care unit with Elizabeth Vanderlaan. Elizabeth is an occupational therapist at Advocate Children's Hospital and recently worked on a study exploring early mobility and delirium management in the pediatric intensive care unit. Let's meet Elizabeth. Today on the Moxie OT podcast, we'll be talking with Elizabeth Vanderlaan about OT in the ICU. Elizabeth is an occupational therapist at Advocate Children's Hospital, and she's a longtime friend of mine. I'm so excited to host her here today. Elizabeth, thanks so much for joining us on the Moxie OT podcast.
Thank you so much for having me. I'm really excited to be here today.
That's so great. So am I. Elizabeth, you're an OT who has literally worked in every level of care. Can you tell us a little bit about your background and why you wanted to talk about this topic today?
Absolutely. So I've been years as an occupational therapist, which is surprising to me. I don't know how that much time passed. With the exception of a little bit of time where I did some travel therapy, I've primarily been a pediatric occupational therapist, either exclusively my day or as a majority of the day. I think I knew when I was in grad school that I wanted to work in pediatrics. That was something that I thought of even as I was growing up, was working with kids. So I'm really happy now that that's something that I've accomplished. When I first started my career, I worked in day rehab, which might still be my favorite level of care, if I'm going to be honest. And I've worked in outpatient pediatrics. I've worked in outpatient adults. It was actually a placement or affiliation in adult acute care at the hospital of the University of Pennsylvania when I was a student, exposed to the NICU. And I really loved the NICU. I spent only a small portion of half of the day there with my eventually, when I moved to Chicago and was looking for some registry or PRN work, Advocate Children's Hospital needed someone specifically to help cover their NICU. And so when I had a little bit of experience previously, I was a good candidate for that. And that kind of then opened the door for me so that I could get to know an acute care environment at a children's hospital again. So despite loving the NICU, I still work in the NICU and I love it. It kind of also led through different needs and coverage and maternity leaves and things to me filling in the PICU and development and quality improvement in the PICU. And I've formed some really great relationships with different members of the medical team, nurses, doctors, PAs, nurse practitioners, as well as my therapy department team. And so it's led to a really fun and fulfilling place for me to work.
That's so cool. And I love hearing your story because as an educator, so often I hear from my students like, well, if I don't get this field work placement, I'm not going to be able to work in this. And, what a great example of, well, you worked with adults in the ICU or in acute care. So, you were able to use those skills to work with kids in the NICU. And, all of our experiences build upon each other, create new relationships like you described. And I think it's really helpful for people to hear.
Definitely. And just to kind of speak on that a little bit more, I think that, because we have this feeling sometimes, especially in a hospital system where occupational therapy isn't as well known as physical therapy, for example, we often have to rely on our creativity and our creativity of our domain in practice so that we can understand what we know and how we can apply it to whatever the hospital needs are in whatever unit we're working in.
Yeah, thank you so much for that. I think it's always really important for us as OTs to know our worth. And I think that this discussion today is really going to add to that. So that's why I'm so excited we're talking about this, which kind of leads me to the next question on my list, which is, I've heard the argument that OT shouldn't be in the ICU. Those patients aren't participating in their ADLs, and so we don't have a role there. So why is it important for OT to be a part of the interdisciplinary team in the ICU?
Well, I'm really glad that you brought that up first and foremost. Let's just get that out of the way, because I think that that couldn't be farther from the truth, actually. And let me preface everything by saying I'm going to be approaching a lot of these questions with a pediatric lens, because that's what my experience is. But with most things in pediatrics, the adult world is much better researched. So we're kind of like taking adult literature and adult evidence and then applying it to pediatrics, whether it's through our own research questions or kind of anecdotally or experimentally in practice. And so there's a whole body of research of adult ICU literature that if someone with a more adult practice or someone who's more interested in adults than pediatrics could find like a plethora of knowledge. My answers, though, are going to be my experience and more pediatric based. So there's so much for OT to do in the ICU. We live and operate as occupational therapists at the crossroads of cognition, sensory processing, physical function, and even way back in our roots, mental health. And all of these areas are incredibly, incredibly important to consider in someone's critical illness journey. I think maybe to understand how OT fits in the ICU, you have to understand an ICU environment. So I'm wondering if people who say OT doesn't have a role in the ICU aren't as familiar with an ICU in general, aren't as familiar with critical illness recovery, and then also might need a little bit of a refresher on, how we break down our practice beyond just occupational performance. So in an ICU, we have to understand this type of hospitalization as just, especially in children, a traumatic experience. It is, there's no way around it. It's negative. We have made so many advances in medicine in many, many years. But really only in the last 10 years, we're kind of deviating from this culture of immobility in an ICU, where we were mistakenly thinking, and when I say we, I'm talking about the medical team, as OTs, we're not making this decision, but the medical team mistakenly was maybe over-medicating or prescribing medications that were had good intentions, but what they were doing was immobilizing patients. So they were sedated, they were more bedridden than what we now know to be beneficial. And so this was having really negative effects. Now, as we're coming to understand that this isn't the way to practice, kind of coupled with the fact that we have more life-saving interventions and people can survive critical illness longer, we're ending up with less mortality, but greater morbidity associated with a hospitalization, specifically with a critical illness, so an acute hospitalization. So what that means is people are surviving their illnesses, children are surviving these horrible illnesses or injuries that they have, but what happens to them after that? So we know now through research that a culture of immobility is resulting in things like more days on mechanical ventilation, an increased length of stay, a greater risk for delirium, which I'll talk about a lot more extensively in a little bit. And, if you're a hospital administrator, this is really compelling because this is really easy to translate into money. But as someone who deals on the people side of it, this is resulting in a poorer quality of life and also just poor functional outcomes long term, just based simply on the fact that people are living. Medical professionals, period. We don't want that. But so there is just kind of this inherent risk associated with hospitalization that there will be a decline in function and a long-term decline in a lot of these different areas. So the physical, cognitive, mental health, etc. There's actually something that's been studied really closely, and that's called post-intensive care And so this is the idea that after an intensive there are mental health issues, not just with in pediatric realm, but with families as well. So there's post-traumatic stress disorder. There's a higher risk of depression and anxiety. There are changes in cognition and changes in intelligence. So this is affecting school performance. Then there's also the things that we're very aware of, which is like the physical aspect of it. So hospital acquired weakness, for example. So at this point, these things are pretty well known in the ICU community, adults and pediatrics alike. It's being studied more and more frequently in pediatrics, but is pretty in adults. One of the interventions that was proposed to combat this was this really awesome interdisciplinary bundled approach to ICU care. And I'm getting to the part where OT is really important because in my opinion, in this bundled approach, we're present in all of them. So it's really easy to, it's just like A, B, C, D, E. So A stands for analgesia. So that's pain management in the ICU. B is breathing. So this is like extubation readiness trials, seeing if people are like spontaneous awake trials and spontaneous breathing trials, meaning if someone is sedated or on mechanical ventilation, testing them to see if they can get off of that. C is for comfort, sedation. So really sedation is a big piece there. D is for delirium. The screening, prevention, and management or treatment of delirium in the ICU. E is early mobility and exercise. And F is family engagement and empowerment. So, I mean, if we think about these areas, I can think about a bunch of things that OT can do and is really highly qualified to address in all of these areas. I have a few favorites, which I'll kind of talk about a little bit more, but, you know, we definitely, the idea behind all of this is advocating for a less pharmacological approach to managing these types of things and using occupation, using engagement, using environmental modification, using task analysis and task adaptation to do all of these things, and really advocating for families and educating families. That's where I think this has been seen to be most successful. And I think as OTs, we're really good at that because that is just one of our primary methods of intervention is education. So as a subset of this bundle and kind of how it transitions into the pediatric world and then how I got involved with it and my hospital system got involved. In 2016, Johns Hopkins did a quality improvement study where they were looking to see if they could take, with no additional materials, with no additional staff, nothing extra, just a little bit of adaptation to the way that they were practicing. If they could use this bundled approach that worked really well with adults and kind of tweak it a little bit and use it in their PICUs. It was very successful. They had no adverse events, and they did see really nice outcomes like decreased length of stay, decreased stays on mechanical ventilation, better functional outcomes. They obviously identified a lot of other areas where they were going, you know, where there's opportunity for more research and study. But overall, this was a really positive intervention. And what was really cool about it was that the huge focus of it was that it was a transdisciplinary model. So this was something that everybody was very well respected on the team. Everybody's role was very well respected. It was not the typical hierarchical model in medicine that we're really accustomed to operating under. So this study took the bundle of A, B, C, D, E, F, and then so they called it Pick You Up, which is a really cute and
love that,
like easy thing to remember. What they did was, it does involve a lot of work on the rest of the ICU, but as far as the early mobility piece, for example, they took a few different, I'm going to stop for a second, back up. So the early mobility portion, which is easy to identify therapy's role in that area, right, especially physical and occupational therapy, they divided into 3 levels of activity and set very specific parameters for when a patient would be able to participate in those types of activities. So this really helps with the decision-making process of the types of activities that patients can do. I think it's really important to note in this context that early mobility does not mean functional mobility. So it's not only transfers and ambulation, that type of stuff. When people ask about OT's role in the ICU and they hear about early mobility, I think you kind of think about, okay, walking patient on a ventilator or something like that. But there's a lot of steps that lead up to that. And in this particular study, OT was actually consulted in the ICU before PT was. So the goal was that the patient was hospitalized for at least 72 hours. It was an automatic OT referral. And this was because of—
That's so awesome.
I know, it was like, wow, I can't believe this. Now, I'll kind of back up. They're working with the staff that they have. This might have been, based on their resources, what made the most sense at this specific university. But the idea is the acknowledgement of, within our domain and practice, our knowledge, our confidence, and where we can practice in the hospital. So for the things in these activity sections, the lowest level activities, the level 1 activity for a patient to be participating in included things like environmental modification, positioning, splinting, sensory stimulation, and discussions with family about appropriate cognitive stimulation, whether the clinician was doing that themselves or if the family was doing things like just speaking to a patient. So let's say that they are sedated, intubated, they are doing coma sim or something. You still should be providing cognitive stimulation to this person. You should be opening blinds. You should be letting daylight come in during daytime hours. So these are all discussions about, the environment and how it can be modified, helping people understand why this is important. And this kind of goes in a little bit to delirium, which I really like delirium, and I've kind of fallen into, at my hospital at least, a role of a go-to person about what we should be doing for delirium. So there have been studies in the adult world and now emerging in the pediatric world again, suggesting that OT has a really strong role in delirium prevention, number 1. The evidence isn't as strong right now in specifically delirium treatment or management, so once a patient becomes delirious. But I think a lot of that is because it hasn't been researched, so it's just we need more evidence. So delirium is important because these are, generally speaking, short-term changes in cognition, often caused by medication, immobility, things that in some ways are preventable in an ICU. So this, to some degree, patients need medication and they need life-saving intervention. However, we have to be creatively thinking about how we can offer ways to stimulate and provide mobility within the context of what's safe for that patient. So it's kind of interesting if you look at delirium literature and what intervention is at some of these things I've been talking about, which also, if you look at the OT practice framework, are areas where it's like very clear. These are very specific intervention areas that OT is very well versed. In fact, I think probably the best equipped on a team of therapy clinicians to handle. So this is things like I was mentioning, cognitive stimulation, sensory intervention. Now this is low-level sensory intervention, so this is going to be things like coma sim or even just movement stimulation, so range of motion. And in that, you're also, preventing deformity, maintaining range of motion. Things like speaking to families about bringing familiar objects. So there's familiar smells, there's familiar things to touch, touching someone. So they seem low level and basic, but no one else is doing them or educating them to be done, number one. But number two, they're incredibly, incredibly important for early recovery from a critical illness.
I think that's so important to think, if OT just comes in and says, it's okay to touch your loved one, it's such a scary situation for the family and they don't want to hurt their family member.
Right.
It's just so amazing to think nobody else has told the family that.
Right. You give them permission. So this, to kind of jump back, this is one reason that this really was a culture change in the PICU. This program was such an amazing thing was, at first it kind of, I would say maybe resulted in more therapy. Maybe not the ones where we're spending a really long time on a plan of care through a patient. Like, I think once the program becomes established, they become more consultative, et cetera. Mm-hmm. But at the very beginning, it was, a lot of therapy orders, a lot of OT orders, so that we could provide education and permission. We get a lot of babies in our PICU, and so helping parents to understand that holding their intubated baby is literally the best thing that they could be doing for them that day. Parents want to feel involved, but they're also really scared.
Right.
So yeah, and it was pretty incredible to watch the transformation, because as I mentioned, this is really a transdisciplinary approach. So once nursing became more comfortable with suggesting these types of things to families, it becomes like part of the routine and part of the day. So, I think with the early mobility portion of it, the idea is that every day there's a goal set for a patient to participate in the highest level of activity or mobility that they can for that day that's the safest for them. So it's based on specific criteria, as I said. Safety comes first, medical intervention comes first. If there's a change of status or something, you might have to change your plan. But, this could look like holding a baby out of bed. This could look like the cognitive stimulation or delirium prevention. This could look like, bringing it back, modified ADL. So maybe a patient is at a point where they're sitting up in bed, but they don't have the core strength to be able to use their arms. They can still work on their sitting balance with their family or with therapy and have their grooming done by someone else. It's still an ADL, but we're working on, the performance skills that are leading up to that. And that's really valid. You can't just go from 0 to 100. You have to work on the skills that are going to support the functional engagement.
That's so much and so wonderful, and such a great way to walk us through why is OT important in the ICU. And of course, as you know, my niece was in the PICU, and our longtime listeners will know that because her mom was interviewed on the show. And I'm just thinking about, we had a little bit of education, so, we were using some of these skills, but I've always said I really wish OT was there with us. And now I'm thinking about some missed opportunities. So hopefully your work will help move other PICUs and NICUs to increase OT's presence. Stepping back a minute, many OT practitioners probably feel really unprepared to work in the ICU. So I guess we talked about how you got there, but is there any special training that an OTP needs to have before they're working in the ICU?
It's an intimidating place, that's for sure. I think, if you've never had like a field work to help facilitate your learning and things like that, I don't think that the door is shut for you. There's definitely opportunity. Um, Especially, I think, if you have knowledge of what can be done in an ICU. So if you come with ideas to an interview, for example, and talk about some of this evidence and things, if there's not an existing program and you want to develop something like that, but you need a little bit of guidance as far as the medical component, all that takes is a little bit of mentorship, either from an existing clinician, someone outside your discipline, um, or even shadowing someone else in the unit itself. So I think that I think you have to be someone who wants to work in a medical environment. That is foundational. If you're not interested in a fast pace where you are challenged to be picking apart your role and understanding the building blocks of it, um, and then being able to put them back together to advocate for yourself and your profession, it might not be the best fit. But I think actually people that have experience outside of the ICU, so someone who has not exclusively worked in an ICU, are really have a lot to offer to a team that works in a critical care environment. I think that, let's say, for instance, you have a lot of sensory experience. That's something really, really valuable that you can offer to the team, and a different way of approaching treatment of that patient that truly no one else on the medical team is going to be doing. In order to do that, I think you need to be willing to dig deep and do a lot of learning. So you'll have to do a little bit of self-study, and look for opportunities to understand the environment and culture. One of the best prerequisites would just be someone who is a confident OT, who loves their profession and wants to think outside the box and creatively about how you can apply it in an environment where you're not only working with patients, but you're working a lot with their families.
Yeah, I think there's so many different ways that we can learn. We can learn, but we can get experience and find our way into an area of practice we're very interested in. Maybe you get a job somewhere else in the hospital and you let them know you're willing to rotate into the ICU.
Exactly.
And I like what you said about bringing, your other experiences in. Kind of off topic, but I'm thinking about a lot when, my primary work was in day rehab, but if I would float onto a inpatient rehab floor, I knew so much more about what was coming next than, so many of the clinicians in inpatient rehab, that's their first job and that's kind of all they know, which is fine. But I found it really helpful to prepare the patients for, this is what you can expect. This is probably where you're going to go. The road's not done when you leave this giant building. And I think, a therapist who's worked in pediatric outpatient could bring a lot of that to the ICU.
Absolutely. I'm finding the longer I work that, every hospital system is different. So at mine in particular, we have like all clinicians staff our weekend coverage. So be an opportunity, as you mentioned, for someone who's like wanting to get their feet wet but not commit completely, is finding a hospital where, if you are more familiar and comfortable in an outpatient setting, you're an outpatient therapist, but then you're trained for weekend coverage, and maybe you're picking up extra shifts, and where there's the opportunity to go and shadow when you have patients cancel or a light day or something like that. It's nice. It's definitely an area though that you have to want to work in.
For sure. I think the cognitive load of making sure that, your clients are safe, and, I'm sure there's a lot of pressures there, but there's opportunity to make such a difference in your clients' lives and their families especially. So I'm so excited we're talking about this. And so I guess as we're talking about how to get into the ICU, if people are listening that are kind of thinking about it, what kind of clients do you typically see? What diagnoses?
A lot of that is hospital dependent. In general, in the ICU, you're going to be seeing the critically ill patients. Now, if you're working for a hospital system, for example, that is not a trauma center or doesn't have a trauma surgeon, you're not going to be seeing trauma cases, just as an example. So that could be ortho trauma, that could be neurotrauma. Like a gunshot wound is a trauma case technically. So we currently don't have a trauma. We're not seeing gunshot wounds. On the neuro side, though, for example, we do see AVM ruptures. We see, like bleeds and some non-accidental neurotrauma. We see, just every other type of neurological event that wasn't a traumatic one. So it is a little bit dependent. Our hospital as well, I do work in the cardiac ICU as well. That is separate from the PICU itself. That's just my hospital, the way that they're structured. But for instance, at Johns Hopkins, that I mentioned earlier, they're all together. So in that study, it was cardiac patients and non-cardiac patients. For us specifically, we get a really good mix. We seem to get a fair amount of infants or infant toddlers. Again, part of that is because we have a NICU, a really strong NICU, and so these kids start in the NICU and then they kind of funnel through our system of care. So when there are complications or require hospitalization down the road, then they're established in our system and they come back. So it kind of runs the gamut as far as pediatrics go. I love the neuro cases personally, but that's part of my background, having been working for a rehabilitation hospital earlier in my career. Really interesting lately has been working with kids that have some multi-system inflammatory illnesses as a result of having had COVID. This has just been a weird year for everybody, I think. And we've had a real big reduction in like other types of illnesses like flu or bronchiolitis, respiratory illnesses, and things like that, which maybe because they're kind of not there, it makes it seem like there are more neuro cases, but maybe not. We do get, fractures and things like that, post-surgical cases, for like ENT post-surgical cases, spinal fusions, just a lot of, it's very different. That's one of the reasons that I love the PICU so much is, generally speaking, kids cycle through there pretty quickly. Those aren't the ones that we are necessarily being consulted on or working with long term. The ones that are in the unit for a longer period of time, you get to see some pretty cool beginnings of progress, establish relationships with families. It's very meaningful. It's nice to be part of a team that is supporting a family through one of the most horrible and difficult times of their lives, and to have been on the other side and to see what happens 6 months later and what hope there is and kind of light at the end of the tunnel.
Yeah, I think, we've already talked about this, but that is just so helpful for a clinician to have seen that and be able to prepare the family for that and let them know there's a future. I think, you're describing so many different diagnoses that you can see, and it's something that you and I and our friends have talked about, that we really like to work in settings where it's different every day, and we're seeing lots of different clients, and we need to do a lot of problem solving. And, I know that's not for everyone. Some people really appreciate working in that hand clinic or that ortho unit, and they like to know those expectations, but I think that's a good thing for us to reflect on if we're considering that career. Um, we may have already touched on this, but do you have any other examples you wanted to share with us on sensory interventions that OTs might use in the ICU?
Sure. So again, because the caseload is so varied and the reason for admission could be, any number of things, you do get different levels of function in the ICU too. So it really ranges from very low level intervention to higher level intervention. We have a program in place at our hospital, and I think a number of hospitals do, to support, we call it an adaptive care committee or adaptive care plan. But this is for kids who have like a known sensory diagnosis, sensory sensitivities, or even just behavioral issues, who, for reasons aside from the medical piece of it, would have a really hard time with hospitalization because they're away from the familiars of their home, they're outside their normal routine and roles. And so with some of these kids, you're doing maybe more like outpatient frame of reference type of sensory intervention. COVID has really messed up a lot of what we can like bring into rooms and things like that. So we've had to get pretty creative as far as materials that we can use and reuse. But yeah, so some of it is support with actual, like you're looking at maybe vestibular, proprioceptive, a lot of that type of care, as well as educating other members of the medical team about how you're going to approach the patient. Whether maybe they don't like to be approached from the front, or maybe they don't like a certain volume of voice or things like that. So a lot of interviewing of the family. Another area that I work with a lot in the PICU, but then also in the NICU, and this is more specific to some of our infant intervention, is the idea of state regulation. And so this kind of falls under the umbrella of sensory processing, but a foundational skill really that babies have to learn in order to participate in their occupations of feeding, of sleeping and sleep hygiene, of caregiver bonding and play. So this is the idea that a baby can maintain physiological stability, all of the different types of sensations that there are in the world. Now, specifically in the NICU, this is interesting because they would be in utero, and so it's a very different environment than what should be happening for maybe the last 3, 4, 5, 6 or more weeks of gestation. But even as infants and even some toddlers, even as they get older and maybe master that skill to varying degrees, the hospitalization again is a traumatic experience, and as it happens with anybody, there's a regression in skills, including this state regulation or self-regulation. And so it's a lot of sensory-based interventions, sensory supports to support the baby or even toddler, so that they can function while there's a medical team having to come and do medical intervention, whether it's poking, whether it's blood pressure, temperature, things like that. All of these things that are a child that young doesn't understand to be necessary. It's just something that's noxious. So that's a whole area. And then the areas that we talked about, kind of ranging from very, very basic low-level stimulation to like desensitization. We do sometimes couple with like speech therapy, depending on what speech therapy's role is in the hospital that you work with. There might be like intervention or sensory feeding, oral desensitization, children that have had intubation, or like a lot happening near their nose and their mouth.
Yeah, and everyone knows that that was a highlight of my niece's sequela after her hospitalization. So I'm certainly aware of how important that is and what a struggle it can be. But I also love that you talked about sensory adaptations or approaches for the clients that had sensory processing issue before they came into the hospital, because I think that is often missed, and then a kid is labeled as a behavioral problem. And what'd you say?
Or difficult or
Difficult, yeah. And I think we need to, we're going to talk about this on another episode of the podcast, but we need to think about how these experiences affect adults as well. But OT has a role with these clients in acute care or the ICU, or maybe primary care, where they're really having difficulty working with the doctor and nurse in the office, and how can we adapt the environment so that they're more comfortable, or prepare the patient or client or family to prepare for that experience. So we talked a lot about early mobility and why it's important. I had it on my list of questions. I don't know if there's anything else you want to add.
Yeah, I think I kind of just skipped over to it.
That's okay. I mean,
no, I think I covered most of it. I think that it was a really interesting approach that Pick You Up used, and anyone who's interested in hearing more about it, their article, which we can link as resources, really does a nice job that would be included in each different type of level. I think just in general, to kind of piggyback off what we were just talking about, is OT in an ICU has the opportunity to cover all bases in all categories. We're talking about primary, secondary, tertiary prevention. We're talking about anything from a consultative service, with talking about how you're approaching someone that has special needs in a hospitalization, all the way up to someone that you're seeing almost like a rehab candidate, where you're seeing them 5 or 6 times a week, multiple times, having really long treatments and working on these really familiar nitty-gritty functional skills that are going to translate to functional gains after a really serious illness or injury. So it's really cool, because you can the possibilities are endless. You can make it what you want, and it really, if you're motivated to learn more and to advocate for yourself and be creative, and also I think it works best when you're taking an interdisciplinary approach, and you're working with other clinicians on the team. I always felt like in day rehab, and in rehab in general, that was something I not only enjoyed, but was a big benefit and strength, was you couldn't do things too many times. Having overlap from what the speech therapist told you they were working on, if you could carry that session, it made it better. It wasn't like you needed to be siloed or pigeonholed. People know what they're confident in and what their expertise is, but you all work together, and I feel like it's the same in the ICU in my experience.
That's so great. And I think that is a good reminder. I think sometimes we have these experiences of turf wars or concerns about losing our position in a certain unit. But if we're all working together and demonstrating our area of expertise, but helping to implement those across the goals and strategies across the board, it's only going to benefit the client more. And the client's going to start to understand why this is so important if everybody's implementing these strategies. So thank you for that reminder of the importance of the interdisciplinary team. It's definitely an experience I've loved as well. We've talked about so many different diagnoses, and I know every client and every situation is different, but could you tell us a little bit about what an evaluation might look like, or what are some of the standardized assessments that you use?
This is an area where I need to do better, I think. I'm trying to advocate for myself. I would really like to be AMP certified, and I think that I'm going to start by listening to Bridget's podcast about it.
Right.
But I know that to be a really applicable assessment tool, because it would be great in an ICU, because you can pick any number of different occupations that you're using, and it works for all these different ages. So I would really like to see us try to move towards identifying more standardized tools that we're using. I think we're kind of right now in that area where we're looking at different skills individually. So we're doing a range of motion, we're doing manual muscle testing, we're doing modified Ashworth scale, doing a basic vision assessment. I think I personally, with the experience that I have in the day rehab setting where we would use things like the EFPT, where I became accustomed to that type of cueing and observation. I think that I use that, but it's not obviously not a standardized assessment, nor is it appropriate for a child, that's that young. But I am able to speak to a number based on my experience with other types of assessment tools that I have experience with.
Well, and I think that's a really good example of taking the skills that we've learned from a formal assessment tool and using them in an informal assessment. And we're still gathering really important information. And if we document that accordingly, that's going to paint the picture. And it is so helpful when we're using some kind of an occupation-based assessment, because not anyone, but many clinicians can do a range of motion assessment or a manual muscle assessment. And we know as OTs that just because you can raise your arm to whatever point doesn't necessarily reflect your occupational performance. My boss at Midwestern, Kim Bryce, she's a huge proponent of taking your AMPS brain and applying it in an informal setting, because maybe you don't have time to do 2 tasks, or the client doesn't want to make exactly what's listed in the manual, but you can still look at all of those different performance skills in any task and get so much more information. So thanks for shouting out AMPS again. Big AMPS influencers in this podcast, and that just speaks to the importance of occupation, I think. Do you have a success story you'd like to share with us?
Well, I think one success story. Did you want a patient or client specific one? I can think of one of those, but then I'll also talk about a little bit more about just this culture of the ICU.
I think those are, both great successes to celebrate.
So our cardiac intensive care unit at Advocates Children's Hospital is very well reputed. It's kind of known, I think, in other places in the country. They're involved in a lot of like national initiatives and things like that. They're like badass people over there.
Yeah. And I can speak to, I've heard that before too.
Yeah, so it's like really well-known physicians, like a little bit intimidating nurses, and like you go up there and you're like, okay, I'm like, this is a serious place where and our PICU is also full of brilliant people, but it's a little bit different culture and environment, I think. Like it feels a little bit different. So it's been really cool at our institution to see the success of this bundled approach and this interdisciplinary model. One thing that we implemented as part of it was we have a morning huddle every single day at 8:30 in the morning. It's brief. It's like 15 minutes. We go through every kid in the unit, talk about their goals for the day, talk about, if they're on the therapy caseload, if they need orders, if them, like how that can be carried over, what type of mobility goal we're going to be trying to set during the day. We communicate anything, from our perspective that has to do with the family or what we're thinking for discharge, or, can we get a PM&R consult because we think rehab, stuff like this. So this huddle has been awesome in improving communication among the team, improving outcomes, I think, for families, and then just kind of perpetuating this culture that we've started to create. And it's been really cool to see these like super like the PCICU or the cardiac ICU is starting to adopt some of this stuff, and now they're like interested in the delirium prevention, and they're interested in early mobility, and they're taking it and like doing it their own way too. But it was kind of cool to be, we're like, look at this evidence we have, and we're gonna, we're influencing them, knowledgeable, awesome people too. So it's had a really cool effect in the hospital that way.
That's so cool to hear, and I think that speaks to when you're doing good work, people notice.
Yeah.
And then, I don't know that we even mentioned that the work you've been doing has been an extension of that Johns Hopkins study. So you will be able to publish your results, and, it feels like a lot of extra work to make something, a research study, but it's really worth it when it helps us influence change for the better.
Yeah. Well, I've certainly only been like one small component of it. I didn't have to do any of the hard stuff like the IRB or any of the data collection and stuff. Johns Hopkins actually did all of that stuff, but it's been incredible to have them as resources. And then part of what we're doing is taking that program and making it our own and seeing if our outcomes are similar and how feasible that is. And I love that the whole point of it is to not get extra staff and to not get extra materials, and it's using what you already have, and it's just changing the way that critical care is approached in your institution. And truthfully, I mean, anyone can start that. It was another one of our OTs, Kara Drujas, that was really a huge proponent of introducing the director of the PICU to some of these studies and talking about like, can we start doing this? It was all kind of serendipitous. So it's been exciting.
That's wonderful. And then did you want to share a client success story with us?
Yeah, so it's always really, really nice when clients come back, patients come back, because typically the progression will go that they have an ICU stay, maybe a really long one. They'll go maybe to just the general floor to inpatient rehab. Depending on insurance, they might say that. Often they go to Shirley Ryan. And then from Shirley Ryan, a lot of times they're going to be going to day rehab. So it's kind of, there's a bit of distance between the PICU stay and then maybe when they might be able to come back if they ever do come back. So some of the successes that we've had, I mean, there are a lot of them to think of, but the ones that are really, really meaningful are, I think for the kids that are really high functioning prior to admission and have a serious interruption in their life and their function, with really, really complicated hospitalization. So things like having ECMO, having multiple days on mechanical ventilation. So I can remember kind of early on when we were just starting to talk about some of these like early mobility and delirium prevention strategies. We had a guy that arrested actually, and he was on ECMO for a few days. And now you'll also hear about doing like ambulation with ECMO now, because that's kind of becoming a thing. Mm-hmm. That's different than the type of ECMO that we typically do at our institution. But what we were able to do kind of as a team in the PICU was optimize his sedation enough that he was able to wake up. He was still not moving that much, but we were doing range of motion, teaching family range of motion. He was using a whiteboard to communicate. And then pretty quickly after he was decannulated and extubated, we were doing things like sitting at the edge of the bed, starting to work on dressing with him, getting him over into a wheelchair, taking him on like little rides outside and stuff like that. So it's really like, you can see how quickly things are able to happen when you are just kind of optimizing all of these interventions and working together as a team and communicating well. So he comes by every so often, and it's really cool to see him and his family. And
That's really great. Thank you so much for sharing that with us. And I think that's a good example of like those little wins along the way. Like, look, that, he's communicating on the whiteboard. That's so helpful for him and for his family to getting back to come to visit. And, I know we all as clinicians appreciate that when we see those long-term results, because it can be hard to see that they're going to get there when you're in the midst of the emergency. So, Elizabeth, at the Moxie OT podcast, we always want to make sure we provide an opportunity for our listeners to increase their Moxie. So if a clinician wanted to know more about OT's role in the ICU, what resources might you recommend for them?
I would definitely look up that Pick You Up study.
And we'll have that on our website.
Yeah, and that was a 2016 article in the Pediatric Critical Care Medicine Journal. There is another article by Tracy Walker in Translational Pediatrics about early mobility in the PICU. That's a 2018 article. There are a number of different delirium articles I can also have you post on the website that I like. But then actually one of my favorite things to do, I don't know how active people are on Med Twitter, but at these conferences, this is like physicians are very, very active. Everyone involved in like the early mobility in the ICU rehab community is very, very active on Med Twitter, which is just Twitter, but for medical professionals. It's not a separate Twitter. But there are some of my favorite hashtags that you could look at. People are actually sharing, they'll post and like if they attend a conference, they'll like post a slide or something that's really interesting, or post videos of patients and cool things that's happening. I mean, it's fun, it's it it's like interesting and like groundbreaking. So it's really like it's motivating and it makes you want to participate. But some of the best hashtags to follow are hashtag illness doesn't mean stillness, hashtag end PJ paralysis. You can follow hashtag everybody moves, hashtag peds ICU, hashtag ICU rehab.
Those are
and then if you follow at Pick You Up being at PickYou_up. It's fun to follow them. The people involved are very, very knowledgeable. If at any point you have the chance to go to one of their lectures or see them speak or have them come to your institution, I've learned an incredible amount from them.
That's so great. Thanks for that, because I think that social media has become a really powerful professional tool. And it's kind of fun, like you said, and it's often in chunks and bites that we can absorb in the moment. And I know that doctors are using it to help each other in tough cases, which is pretty interesting. So those are some great examples. Thank you. And thank you so much for joining us today. This has been really fun.
Thank you.
Thanks for joining us for this meaningful conversation with Elizabeth Vanderlaan on OT's role in the ICU. As Elizabeth mentioned, the recent study she was a part of was an expansion of a 2016 QI initiative at Johns Hopkins that compared the outcome of implementing the interdisciplinary bundled program in various hospital sites across the country. Advocate Children's Hospital was one of a number of sites involved. The 2016 project included a usual care baseline phase, which was followed by a quality improvement phase. The QI phase focused on early mobilization of critically ill children through a multi-component, interdisciplinary, and tiered program promoting early mobilization. The program increased early mobilization through additional PT and OT participation in the children's care. Elizabeth provided us with a plethora of articles, so we'll have links to all of these resources on the Moxie OT website. If you want to be a part of the conversation, leave us your email at our website. We're on all of your favorite social media channels as well. Please like and subscribe so others can join the conversation. The Moxie OT podcast was recorded in our home in the Avondale neighborhood of Chicago. This episode was produced by Brian Zira. Our intro music is courtesy of 13 Tacos Studio. Technical assistance was provided by our dog Grody. Thanks for joining us. We'll see you next time.